Good afternoon. Welcome to APPA's second town hall on sharing emerging practices on COVID-19. My name is Billy Zadig, Standards and Codes Administrator for APPA. Just a couple of housekeeping items before we get started. The town hall recording will be posted later this afternoon on our website. You will also receive a follow-up email in the next couple of days with a link to our COVID-19 webpage. All attendees are in listen-only mode. Please type your questions in the chat box and they will be answered in the order they are received. If we run out of time and we still have questions, responses will be sent directly to the person asking the question by one of our panelists. Question and answers will be posted to our website. At this time, it's my pleasure to turn this over to Lander Medlin, who will be your moderator today. Lander, take it away.
Thanks, Billy. I appreciate that and all the ground rules, and hopefully everyone has unmuted their own speakers so they can hear us. I want to welcome everyone and appreciate the last town hall. We had a similar number. We have hit capacity at 1,200 attendees. We appreciate every one of you being on this call. And at the last town hall, we're going to build off of that town hall. And I want to let folks know that we had questions and we have responded to those questions in a Q&A section of, instead of FAQs, frequently asked, it's RAQs, recently asked questions. Clever, yes, because they really were recent, and we'll build off of that again. We'll be doing this every Friday until as long as it makes sense to do it on different topics. So stay tuned. I really appreciate everyone joining this dialogue, because that's truly what this dialogue, this is about. There's an important focus today, as you will see, on increasing our understanding on COVID-19. Given last week's extensive questions around the virus, its biology, our cleaning response, and so many other things, we are ecstatic about having a health expert, Dr. Huey, of the caliber available to speak with us today and answer questions. And we believe many of your questions are going to be answered before you even ask them. Now, the other thing I want to remind you of is that this is emerging practices. It's not best. We don't know yet. We're all rookies at this, given the uncertainty and the uncharted territory. Our panelists are going to help us build off of that today in that particular area as well. So let me give you the format. I'm going to give you a brief intro, give you some content areas that we're going to cover with the health professionals' understanding of COVID-19. I'm going to move to what's happening across a new set of 3 very different institutional types, and then a themed conversation by each of the panelists, some Q&As after the health professional and then thereafter, and then we'll conclude with some available resources and closing remarks. So let me start with a short intro. I want to contrast with the coronavirus statistics from yesterday and then the prior weeks, because it's going to reinforce the exponential change concept, and it is changing exponentially. So last night we hit 85,500 cases in the United States alone, 1,300 plus deaths across all 50 states. I want to tell you that last week, 3/19, last Thursday, there were 13,000 cases and 193 deaths. The week earlier, 3/12. There were only 46 states in the United States. Canada was just getting touched, and there were 1,500 cases and 17 deaths. 2 weeks before that, which was 3/5. And remember, we're still in March here. There were a handful of states, 200 cases and 0 deaths. We have now surpassed China in the number of cases and deaths. This is a whole new world, and it is exponential change. So you need to think differently, be anticipatory, and our panelists are going to give you some ideas in that regard. I want to continue to stress the importance of social and physical distancing. Model this in facilities. And then I want to now transition to our first content area, which is our health professional, Dr. Michael Huey. Dr. Michael Huey is an MD and an associate professor of family and preventive medicine at the Emory University School of Medicine and a member of the American College Health Association COVID-19 Task Force, and we appreciate that, and ACHA giving us him. In 2015-16, Michael was an Ebola clinical consultant with CDC, National Center for Emerging Zoonotic Infectious Diseases, and he deployed with the CDC Sierra Leone Ebola response as an infection prevention specialist in summer of 2015. This is a no slouch guy. Let's listen up and prepare to ask questions as he walks through the following content areas. I hand it over to you, Dr. Huey.
Thank you so much, Lander. And I'm going to try not to slouch. I might be slouching a little bit because I'm not on camera. So thank you for that. It really is a pleasure to be here today and represent the American College Health Association and all of your colleagues who are working in healthcare across our nations, both the United States, Canada, and beyond. APPA and ACHA are partner organizations, and we're working hard to try to share our expertise across our disciplines. And so that's the reason for me being here today. We're going to start out with a quick overview of SARS-CoV-2, which is the virus responsible for the 2019 disease known as COVID-19. And so we'll look a little bit first at the virology and epidemiology of this virus and of this family of viruses, because coronaviruses are a large family of viruses. They're common in both human and animals, and there are currently 7 human strains. 4 of those strains have been around for a long, long time, and they have been responsible for mild to moderate upper respiratory illnesses, colds, and other type of flu-like illnesses, not influenza, which is a separate family of viruses, but flu-like. There, unfortunately, have been 3 other strains of coronavirus which have impacted human beings and caused severe illness. The first was known as SARS, of which that virus was SARS-CoV-1. The second was MERS, the Middle Eastern Respiratory Distress Syndrome, and now we have SARS-CoV-2 causing COVID-19. Why is this virus spreading so exponentially? The answer is because it's a novel virus. This is a virus which no human being has had previous infection from. So everyone is susceptible to this virus and no one is immune. Just quickly, viruses are a very simple organism. They are an envelope of protective protein, or in the case of SARS-CoV-2, a lipid envelope, a fatty envelope, and inside is genetic material. And for this group of viruses, for this family of viruses, they are RNA viruses. They are ribonucleic acid and not DNA viruses, which is the genetic material of human beings, for example. And these viruses invade the cell, and then they copy their genetic material, and they copy their envelopes, and then they explode those cells. They lyse those cells and move on to adjacent cells in their target tissue, which for SARS-CoV is essentially respiratory tissue. So one good thing is that SARS-CoV does have this fatty envelope, and because of the fatty envelope, it's susceptible to soap and water, just like if you were washing the pan that you fried your pork chops in last night, and you put it in soap and water in the sink, and that grease, that lipid, emulsified into the water and dispersed. That's what soap and water does to SARS-CoV. So it's a very effective approach, and frankly different from what many of us have experienced in both healthcare and in facilities management with infections like norovirus, which has swept across many of our campuses. Probably many of you listening have had norovirus outbreaks on your campus. Norovirus is not susceptible to soap and water in the same way that SARS-CoV is, and that's why we had to use chlorine-based cleaners, and we had to use gel-based hand sanitizers when we were dealing with norovirus, not so SARS-CoV. Next slide. So what are the symptoms? And I know that all of you are familiar with this. I'm not going to spend a great deal of time on it, but with COVID-19, we have had illnesses ranging from very mild and in many cases asymptomatic to severe illnesses. And those severe illnesses, unfortunately, can go on, particularly in high-risk patients, to cause respiratory failure and death. The common symptoms of COVID-19 are familiar to all of us. They include fever, cough, muscle aches and fatigue, and shortness of breath at the onset. There are other less common symptoms. The most common of the less common symptoms would be sore throat. And some patients have reported gastrointestinal symptoms such as diarrhea or nausea and vomiting prior to the development of fever and lower respiratory tract signs and symptoms. And there has been a flurry of information in the media recently about other symptoms which may be indicative that your infection is with SARS-CoV and not with other respiratory infections. And those have included loss of sense of smell and loss of sense of taste as early symptoms. And so were you to develop those symptoms, it's something that should immediately call your attention to making contact with a healthcare provider virtually and seeking information and advice. Next slide. So this is an important slide, and this is from a researcher, Ian McKay, in Australia, about the course of infection with COVID-19 and how long are people infectious. And so the top part of this slide is a graphic of what happens when you get infected. So you have the onset of infection by the virus, and there is an incubation period, and this is true of all viral infections. So there's an incubation period and then a symptomatic period. The infectious period, to greater or lesser degree, depending upon the virus, overlaps into the incubation period. So that pre-symptomatic period where a person is infectious and that infectivity increases in its severity over the time of that pre-symptomatic but infectious period varies from virus to virus. So what do we know now about COVID-19? And it's important to say that this is an evolving understanding of the way that this virus operates. And we're learning more and more all the time as research comes out. There have already been thousands of papers published on COVID-19 just in a very short period of time since the turn of the year. So again, this is evolving information. But for COVID-19, the mean incubation time, which would be that time from exposure until you have your first symptoms, has been 4 days. And so it can vary across the incubation period, but the mean is 4 days, and 98% of people develop symptoms within 12 days. And that's the reason for the 14-day periods of time that we're going to talk about in just a moment, is because by day 12, we should have 98% of infected persons displaying symptoms, and then over the next 2 days, that number will increase. So what is that pre-symptomatic period with COVID-19 where a person may be infectious and yet not have developed symptoms? That pre-symptomatic period is now felt to be 24 to 48 hours. Next slide. So I know that we talk a lot about quarantine and isolation. These are actually terms that have set definitions, and you see them used with good intentions but incorrectly on a regular basis. So let's just talk very quickly about the definitions. What is quarantine? Quarantine is for people who have been exposed to a known case of an infection but are well. Isolation is for people who have been diagnosed with an infection And then what is observation and monitoring, and self-observation and self-monitoring? These are periods of time where people who have been in at-risk situations or at-risk occupations but have not knowingly been exposed to the infection are monitoring themselves for symptoms and for fever. So for COVID-19, as I said earlier, 14 days has been the standard period for all three of these situations. I will tell you that CDC came out with a new set of guidelines on the 17th of March. Again, things are changing so rapidly, where there now have been some revised sets of criteria under which the isolation of individuals who are infected may be able to be reduced from 14 days, depending upon a complete resolution of symptoms and a period of time following that complete resolution. The other point that I wanted to make is that CDC is a guidance organization. It's an advisory organization, and it gives guidance about quarantine and isolation. But it really is your local, territorial, tribal, or state health department that actually make decisions about who should be quarantined or isolated, when should they be quarantined and isolated, and how should that situation take place. So it's really important for those of us who work at colleges and universities to have a very close working relationship with our health departments, again, our local, territorial, tribal, or state health departments, and to follow their instructions. Next slide. So who's at risk and who's at increased risk for COVID-19? Well, everyone is at risk because it's a novel virus. And so no one is immune, as we talked about earlier, and it's important for all of us to follow recommendations and guidance about ways to protect ourselves from infection. But there is a subset of individuals who are at increased risk for this infection, so let's talk about them, because some of them may be listeners on this call, or they may be co-workers, or they may be our students, faculty, or staff that we work around on a day in, day out basis. So who are these individuals at increased risk? And these are the current list from CDC. Once again, we've got an evolving situation here. So persons who live in places with ongoing community spread of COVID-19. That pretty much is everybody now. So some of these risk categories are becoming moot categories because we do have ongoing community spread across communities in the United States and increasingly so in Canada. Healthcare workers who are caring for patients with COVID-19, close contacts of persons who have COVID-19, so family members, for example, travelers returning from affected locations. Again, we are in a situation now where we have a global level 3 in terms of travel restrictions, which we'll talk about on the next slide. So essentially, it also is becoming a moot point. Many of our healthcare organizations have stopped asking about travel history as they check patients in. Persons who are over what is now increasingly being used is an age of 65, and in some of the recommendations, the age of 60 is used. I happen to be in both those categories, and I know some of you are as well. People with chronic medical conditions, here's the list, and people who are pregnant, which is not a medical condition, but it is a situation that could put an individual at increased risk. If you have questions about what your level of risk is, and very importantly, if you have questions and you are feeling ill and you're trying to decide where am I in terms of my risk, there are some helpful tools. These are the two that I have put on this screen, and once again, this webinar and this set of slides will be made available to you afterwards. But Emory Healthcare, where I work, has a self-check COVID-19 website where you can go in and you can answer questions about whether you meet any of the risk categories, and then you can list your symptoms, and the website gives you suggestions of next steps. It is not it's not something that should be used exclusive of the advice of your healthcare provider, but it does give you some additional information as you're trying to make your decision about whether or not you would want to make that contact. And secondly, CDC has a similar COVID-19 symptom test website, and the link is there. Next slide. An important CDC guidance document for institutes of higher education was last updated on March 21st, and there is a subset of this guidance which is specific to administrators at institutes of higher education. So here is the link, and that's below it is a picture of what you'll see when you log on to that website. So if you haven't familiarized yourself with this yet, I would highly recommend it to you as a place to go take a look. Next slide. So what does CDC say at our institutes of higher education? What should we be doing before we have any risk situations? So in many ways, perhaps in all ways, these are things that we should have done by now. So these would be all institutions encouraging your staff and members of your community to protect their personal health, posting signs about the symptoms of COVID-19. And if you go on to the CDC website, the CDC COVID-19 website, there are excellent signs to download. I think that having that CDC logo prominent on the sign is a great way to give that posting of the sign some additional gravitas and make people take it very seriously. The respect for CDC is very high across the country. There are some questions that have been put out by the media, and CDC scores at the top of agencies that people trust. And so, so using their signs makes a lot of sense to me. Encouraging people to stay home when they are sick until they have been appropriately evaluated, either in person or virtually by their healthcare providers. Cleaning surfaces that are frequently touched, and this is in red because this is a big area for all of you, including shared things like desks and countertops, electronics, doorknobs. Doing a pass-through in your areas where you are responsible for the cleaning, and doing it not as a facilities person or as a facilities administrator, but as if you were just a member of the community that uses that space or visitors that use that space. What would you have touched as you walked through that space or worked in that space, and then concentrating your efforts on those areas. We've already essentially eliminated events and meetings on our campuses. The date at which we're resuming those things is unclear. Staying up to date with the developments in your community. All of us, I know, have an emergency plan for possible outbreak, or we're in the final stages of creating that plan. Intimately acquaint yourselves with what is in that plan and what are the branch points for decision making. And then assessing if you have community members, if you have employees or co-workers who are at increased risk, and then planning the approach to the working situation for those individuals accordingly. Next slide. Okay, so what is the way to address high-risk employees who work in at-risk positions? This is an extraordinarily difficult question, and it's a question that you're likely going to be instituting on a case-by-case basis, and very importantly, when you're making decisions about an individual and protecting their health and safety to the absolute best of your ability, you should be protecting the privacy of that individual employee. So thinking about these things in advance, deciding what your at-risk positions are and your job assignments are in advance so that if you have high-risk individuals, you can assess what might be the best possible role for them in continuing to provide services to your college or university, or whether or not you may need to consider excusing certain individuals from the workforce. These are things that you're going to want to involve your general counsel and your appropriate senior leadership, and making sure that you're once again doing it on a case-by-case basis and considering whether or not this high-risk employee is able to safely complete his or her duties, or whether they are in a situation where they may be able to complete their duties or other duties for which they are qualified in a remote setting. The other level of this is many employees have high-risk family members, and this takes you to a whole different level of complexity. I don't have a separate slide on this. What I will say is that, once again, you're going to be looking at these situations on a case-by-case basis. You're going to seek advice from your appropriate senior administrators, from your infectious disease and infection prevention and control colleagues, and you're going to make decisions about whether you need to change the situation for employees who may have direct responsibilities for high-risk family members. Some institutions are figuring out ways to provide housing for certain high-risk, for certain employees who are vital in their role, have high-risk family members but are not individually responsible for providing the care to that high-risk family member. So there's no cookbook here, and you have to address these things individually. Next slide. I'm going to just hit some highlights on current cleaning and infection prevention and control. This is a topic which could use up this entire 30 minutes and every single slide, and so I've chosen one area to specifically address, and that is, what do you do if you have an employee diagnosed, or a student diagnosed, or an individual diagnosed with COVID-19, or a person who is under investigation for COVID-19, and they are in areas that you are responsible for the cleaning and safety of. These are the current sets of guidelines by CDC for working and addressing this situation. The first is, if it is possible, if you have a confined area that has been used by a person who is now a known case, opening up outside doors and windows to increase air circulation to the area. And by this, again, you may not have outside doors. All your doors may open to interior spaces, but if you can circulate the air into this area and then wait as long as possible, up to 24 hours, before you send in personnel to clean or disinfect the area, that would be ideal. The next step would be to clean and disinfect all areas used by the sick person, and here's a list of things such as common areas and bathrooms and shared electronic equipment, etc. You want to use either EPA registered hospital or EPA registered household disinfectants that have labels that say that they are effective against other respiratory pathogens, which would include influenza, and in some of the labels now it may actually say that it is effective against coronavirus. I know that all of you are already looking at your disinfectants and trying to determine if they are appropriate to use with coronavirus, and if so, you need to carefully follow the directions for use, paying special attention to important items such as wet times. If you are in a cleaning process in these spaces, your minimum PPE would be disposable gloves and gowns for all aspects of the cleaning process, including handling trash. There may be certain situations under which additional personal protective equipment could be indicated, And as you know, the other items include face shields, personal or surgical masks, and respirator type masks or N95. You're going to want to ask your infection control professional or your infectious disease professional if you are entering into a situation where you think that there is a risk of splash or airborne exposure. And these are situations that have to be handled on a case-by-case basis. But the basic PPE for cleaning spaces for COVID-19 is disposable gloves and gowns. These gloves and gowns need to be removed carefully or doffed to avoid contamination of the wearer and the surrounding area. So you want to be sure that your staff is trained both in the use of disinfectants and in donning and doffing techniques. On a slide update, which we didn't get to here, there actually is a link right here on this page, so it will be available to you, I think, when these slides are posted. But Emory University, for example, at www.med.emory.edu/PPE has a set of posters and videos on appropriate donning and doffing, both of high-level personal protective equipment, including N95s and respirators, down to airborne exposure PPE, and that is available to you. It would be worth looking at, remembering that it covers the entire spectrum from healthcare to facilities, and you're going to need to dial to what is proper for the individual area that you are cleaning. Next slide. I'm not going to go into detail here about hand washing, and I know that we're going to want to be moving on very quickly to our question and answers, but hand washing is our absolute most important protection against COVID-19. It's obviously not the only protection, but you want to wash your hands often with soap and water. You want to cover all surfaces of the hands, including between the fingers, and you want to have it be in running and, if possible, warm water for 20 seconds. And if helpful, to have a song in your head or a poem that you recite in your head that takes 20 seconds. And so you do hear recommended. One of the common songs is to sing the Happy Birthday song at its normal pace twice through, and that takes 20 seconds. Always wash your hands immediately after removing your gloves and after any contact with an ill person. If soap and water are not available and your hands are not visibly dirty, you can use an alcohol-based hand sanitizer that contains at least 60% alcohol. But if you have visible soiling of your hands, you must always wash your hands with soap and water. Other key times for hand washing include the things that we do in our regular life, which is you want to wash your hands after blowing your nose, coughing or sneezing, and covering that cough or sneeze. You want to wash your hands after using the restroom, before eating or preparing food, after contact with animals, and if you're providing routine care to a person who needs assistance, such as a child. Next slide. This is a connection on this slide and the next slide to the Johns Hopkins website. CDC has a website, WHO has a website that updates the global and country by country numbers. The Johns Hopkins website is really very, very useful because it updates on a frequent basis throughout the day, all through the evening and night, and on weekends. And so these were the numbers from last night that Lander referenced earlier, with over 531,000 global cases and over 24,000 deaths in 163 countries, which is a death rate by this simple calculation. Now remember, these are symptomatic cases that have been identified, and not every person who's ill seeks medical attention. And so based on these numbers, That's a 4.5% fatality rate. In the United States, the numbers have gone up exponentially, as Lander pointed out. We are now, as of last night, at 85,500 cases with 1,300 deaths. There are cases in all 50 states and in several territories. This is a 1.5% death rate, which is better than the global numbers, but still obviously alarming and significant. And at this point, that thing that we are all looking for and praying for, the flattening of the curve has not yet flattened. We have community transition in most areas of the United States. We already talked about the State Department global level travel advisory, which was published on March 19th. And one important note from CDC last week that I want to share with you is that a sizable proportion of the hospitalizations in the United States for COVID-19, and that number is approximately 20% at this time, is occurring in young adults between the ages of 20 and 40. So this is an important message that we want to convey to our college and university students, faculty, and staff, and visitors, is that although COVID-19 generally is a more serious infection for people who are elderly or in high-risk situations, it is a serious infection for everyone. And so we want our students, our young adults, members of our community to not make the assumption that if they get COVID-19, it will not be a significant infection. That is an unwise assumption to make. Next slide. This is the Johns Hopkins site, what it looks like if you log into it. And it doesn't look like I put the link on this slide. This is from 2 days ago, I believe. Yes, from 25th in the morning. And so if you just Google Johns Hopkins COVID-19, this will be the first hit. And what this allows you to do is look at numbers in countries across the world. But if you click on a country in the left-hand column, then on the right-hand column at the bottom, you see the current curve. So the United States curve right now is continuing to go upwards, and what we are looking for is for it to begin to flatten out and plateau, and we're not there yet. Next slide. We've talked a lot. Actually, this is the slide that ultimately I decided to skip over, and you may have some questions about these, but we'll address those questions if they come up. Let's go to the next slide, because I really did want to talk about your mental health and well-being. And so much of the attention in the media and in our discussions with each other, and frankly in my presentation today, has been focused on physical, on symptoms of the disease, on the clinical course of the disease. But all of the things that have impacted us as individuals and a society, these emotional, social, and financial disruptions have created incredible stress and anxiety and fear in ourselves and in our co-workers. And we have been telling the members of the public to socially distance. And that's an unfortunate term. Many people feel in retrospect we should have used the term physically distance, because we are socially distancing from each other, and it's having an impact on us. And so these stressors get magnified. And what we really need, a colleague of mine in mental health suggested earlier this week in an email, what we need is physical distancing and social solidarity. And so I encourage all of us to think about perhaps just tweaking the terms that we use a touch and going to physical distancing. These stressors that we've talked about, they're magnified in all of us, all of you on the front line. And that includes people in healthcare and people taking care of our facilities and all of the hands-on activities that are necessary in support of the essential services in our campus communities. And so there are self-help resources available to you. There is your employee health or faculty staff assistance program. your college health services and your college counseling services. So many of these now are building up increasing amounts of available information, which you can access virtually. You may have your own mental health professional. Be sure that you don't forget to stay in touch with that person who has helped you for a period of time, and for many of us for a long period of time. And so making sure that you are keeping yourself physically and mentally healthy during the pandemic is so important to your ability to continue to put in work during this stressful time. Next slide. These are a series of links to websites and self-help recommendations that might be beneficial to you. CDC has a set of guidance. The Tang Center at the University of California, Berkeley has posted tips on managing fear and anxiety. Many people in college health are looking to a coronavirus sanity guide, which is published by 10%.com. I'm not trying to push an individual product. I can just tell you that I'm seeing a lot of suggestions that this guide can be helpful. And once again, your own campus will have online mental health support resources for staff, faculty, and students, and telemental health services, and increasingly telemedical health services available for your students. Next slide. This is just a copy of the ACHA guidelines of preparing for COVID-19, and it's starting to outdate. So I just want to give a shout out to the members of the ACHA task force who worked so hard in late February and the first 3 days of March to put this together and to publish it to our ACHA members and make it available to all colleges and universities, including non-members who don't participate in the American College Health Association. And it has a lot of things about preparation, but also about your approach were you to have an outbreak on your campus, which is essentially the situation that we're all facing. Next slide. So we're not going to be able to address all of the questions during this session. We encourage you to continue to participate in the APPA COVID-19 online community, and we'll have answers to the best of our ability, and we'll probably be grouping questions into general topics, so don't be disappointed if you don't see your actual question exactly the way you typed it, because I suspect there are hundreds of questions by this point. But I'm going to turn it back over to our moderator, Lander, and it's time for us, if we can, to answer questions or to at least suggest where you might go, which would include CDC and your local territorial, tribal, or state health department. Lander.
That's excellent, Dr. Huey, and we so appreciate you doing this. And we do have time for questions. We have a fair number of them, and I have gonna pose some of them to you. There's a number of questions on HIPAA and the privacy issues, and they're asking, is it legally correct to be informed so that folks can take the necessary measures to prevent any further spread and that sort of thing? And so sort of some guidance on how do we walk around the privacy HIPAA issues in order to make sure that we are knowledgeable of who, and then we can do contact tracing and that kind of thing. Do you have any suggestions for us on that?
Yes, so Health and Human Services, United States Health and Human Services, HHS, published interim guidelines last week on relaxation of HIPAA in the face of the COVID-19 pandemic. So that would be the first place I would suggest you look, and there may be FAQs associated with that document now. That would not be a surprise to me. But essentially, to put it into a quick statement, what those guidelines say is that the appropriate use of non-public facing online platforms for the telehealth and telemental health provided to patients in the United States will be allowed under HHS guidelines. And so there are a lot of subtleties in that. I'm not the most technologically advanced person. I may be in the lower 5% of technologically advanced people that are on this call. But what I do know is that an example of a public-facing system is Facebook, and an example of a non-public-facing system would be something like FaceTime or Zoom or Skype, if they're used in a one-on-one contact between an individual healthcare provider and an individual patient or client. So the one very important issue that is still being explored, and that I can tell you that ACHA and ACE, the American Council on Education, is engaged with our government on discussing the importance of this issue, is the issue about providing care across state lines. And so for many of us, members of our student body are no longer on the campus, but they are in other states. And so can we provide care, and how is that affected? And is there an impact based upon HIPAA on going across state lines? And what about the fact that for many of the areas of healthcare on the majority of our campuses, that care is actually managed by FERPA and not by HIPAA, and by a very special section of FERPA, which is the treatment section of FERPA. So different from what many of the people on this call deal with in FERPA, there are a whole subset of very HIPAA-like guidelines in the FERPA guidelines that those of us in college health and counseling follow. So the answer is go look at the HHS document and then engage in discussions with your health and counseling people on your campuses and with the general counsel and senior administration of your campuses.
Excellent. I'm going to ask you another one. We're talking about the cleaning of space being able to open air from the outside for the first 24 hours prior to entry, so that you get that circulation first. If we have closed off spaces where there is no ability to open, what about HVAC airflow requirements? And you may or may not be able to answer this, but temperature, runtime, supply, airflow. What is there any a practice recommended in terms of that area?
Well, in situations in a hospital, and frankly in situations in many of our student health centers, there are spaces that have negative pressure airflow that vent appropriately through systems that don't recirculate air. And so that is the perfect situation. As we know, and is going to come up on further questions in a lot of areas, including the questions about face masks, which I know are out there. We can't always achieve the perfect situation, and virtually nobody has these sorts of ventilation situations in residence halls, for example, or in office spaces, for example. And so seeking the advice of your infection prevention and control colleagues, either in your local, state, tribal, or territorial health department, or your infection control people if you're on a campus that has an academic health center, or your infectious disease colleagues in your community or on your campus, and describing for them what your situation is, what kind of room you have, what is the room that you are attempting to disinfect, and under what circumstances could that room be open to a normal ventilatory system once again, I think is really important. And so I'm hesitant to give just a blanket answer, because I think that it's something that you're going to want to try to individualize to your specific situation. And I apologize if that sounds like I'm dodging the question, but I want to make sure that I don't give a simplistic answer that in your very specific situation would not be the proper answer.
I think that's very fair, and that's great advice. If gowns are not readily available for non-healthcare or even masks, etc., can you still clean the areas with proper hand hygiene and even gloving without the gowns and dealing with a lack of masks? We're not issuing N95 masks, let alone the counterfeit ones that are rolling around out there to non-hospital personnel. And so we're just looking for a little guidance on that.
Right. So there are tremendous concerns across our countries about personal protective equipment, and very specifically masks, but also gowns and even gloves. And so CDC is trying to provide us with as much information as they can on an ongoing basis, and this information changes on a daily to weekly basis. So going back to the interim guidances is very, very helpful. So CDC has a set of guidelines about, in a healthcare situation, what you do if you do not have access to N95s, and what you do in a cleaning situation if you don't have access to all of the proper personal protective equipment. And these answers are not perfect answers, because it's if you are in a situation where you don't have a disposable gown, it is not a perfect situation. What I would say to you is, if you have a space with a known positive COVID-19 patient, that I would, before you move in to clean and disinfect that space, that you take every possible step you can to identify any possibility that you could have access to the appropriate PPE, which for that space would be a gown and gloves. If you cannot, then I think you're in a situation that is not ideal. That would be a circumstance under which, first of all, I would think about who is the person that would be asked to potentially clean that space. So you're going to want to think about who has risk factors for COVID-19, and were they to get ill would be at higher risk. And then I would say that the next step between or after a disposable gown would be an apron that is non-permeable. So some of you may have access to those. Certainly those are things that we use. For example, in Ebola situations, we had not only disposable gowns, but Ebola workers also had non-permeable aprons that were put on over top. So it is something that we have used in healthcare settings, and I believe would be available to some of you in facilities management. And finally, a permeable gown, so a reusable cloth washable gown. But there's a sharp drop-off in the safety protection, and so I would say that you want to do everything that you can do to identify access to these gowns, and you want to be sure that you're not using them in situations where they are not indicated for use, because that's one of the things which is leading to the shortage, is the feeling that everybody ought to be in a mask and everybody ought to have a gown on, and I'm going to wear a gown and a mask when I ride my bicycle. And when we move on to that, then we find ourselves in situations, unfortunately, where we really do need that appropriate PPE. And I don't want to minimize that. We're seeing all sorts of stories from across the country of situations in healthcare and in community and college situations where the PPE supply either is run out or is about to run out. So it's a big deal.
It is a big deal, and we totally get it. So I am going to close off questions now with Dr. Huey. However, I will take the questions that were asked, and I will seek answers through and with you, Dr. Huey, your colleagues, and through Devin Job, who's my counterpart at ACHA, to see if we can't get responses to those at that point. I think that may be the best way for us to continue to pursue, as we are making all of the questions that are asked responded to on our website, COVID-19 RAQs, which stands for Recently Asked Questions. You can go right to APPA's COVID-19 resource page and find it right there. Okay, so I want to thank Dr. Huey. Thank you so much. And I know you have a COVID-19 task force meeting right now going on that you have to go to. So we really appreciate your time and such a great presentation. Thank you again, Dr. Huey. And we will be in touch, okay?
Thank you so much. I'm going to stay on the line just because I can. So
okay.
So thank you. I'm going to mute my microphone, and I'm ready to start learning as well as teaching.
All right. Well, there you go. So thank you again. Now we're going to go to our panelists, and I want to ask them what's happening across the three very different institutional types. I'm going to start with Dave Button at University of Regina in Canada, because we have not addressed Canada. He's going to talk to us about regulation and some institutional decision-making and guidance. Dave, over to you.
Well, thank you very much, Lander. Appreciate that, and it's an honor to join with my university colleagues to help share in this terrible situation. I'm going to speak a little bit about the Canadian experience and how we're reacting up here. And I guess in some ways we're somewhat lucky in that we've had a chance to learn from other experiences, as we're one of the leader areas to be touched as this moves rapidly around the globe. So hopefully some of the strong and early interventions will help us in our part of flattening the curve. Until recently here in Canada, all the known COVID cases have been travel related, and this is beginning to grow because, of course, now is the time of the year, particularly as borders close, that the spring breakers and snowbirds are all coming home. And that's why you'll hear an awful lot of emphasis in Canada on self-isolation. Out of interest, every province, which is equivalent to your states, every province has declared a state of emergency. So it's being treated extremely seriously here. All non-essential business have been legislated to close, and guidelines for social distancing have been strongly enforced. Indeed, yesterday at the federal level, they've invoked the Quarantine Act. So they've actually made it not only clearly illegal, but you can go to jail if you don't self-isolate in the prescribed situations, which in particular is any international travel. And to go even further, some provinces have invoked those same regulations about self-isolating for 14 days if you've even traveled interprovincially. So lots of fines and jail time, et cetera, to just emphasize the importance of self-isolation and staying away from one another. As has been mentioned, I think it exists everywhere. All events of any sort have been canceled up here in Canada, and regulations go as low as, in some places, even meetings in groups of more than 5 are prohibited. Specifically in the university sector, 100% of the universities in Canada have canceled our face-to-face classes for the rest of the winter term and moved to new online and remote modalities. And many universities have moved to, say, a pass-fail system for marking for during that term as well. In terms of K-12, same thing. Across all provinces, classes canceled for the rest of the year. Students given a pass to get into their graduating into the next year in all those cases. Most campuses have totally closed their doors to the public, but of course remain open for limited hours and for critical services to directly support the mission of teaching and a much reduced research activity. And that's evidenced by things like libraries, etc., being totally closed. 50% of the Canadian universities have already declared that spring and summer classes will be delivered remotely, and I suspect that that figure will increase to about 100% within a week or so. In essence, to continue this theme of social distancing, which is anticipated to continue for months now. As of today, more than 60% of universities have canceled things like graduation ceremonies, spring convocation, etc. The intent of the legislation, the political guidance, has been to significantly reduce the number of possible contact vectors, and the universities are taking actually a strong lead on this and following through. And as a result, all activities are being done as much as possible. And it's amazing within the last week or so how much we've moved from physical to online activity. I'm sure most universities are similar to mine. We'd estimate that the physical activity level on campus is down at least 95%. Residents, etc., are closed as well, other than, of course, being a home for those that have no other home, and in particular international students who either left it too late to go home or just can't get home. So in short, here in Canada, the direction to social distance has been fully supported and is in place to take and flatten the curve and hopefully minimize the impact of COVID-19. I'll turn it over now to my colleague, Kevin Folsom in Texas.
Thank you, Dave. I have a 2-hour commute to work daily. And about 3 years ago, I learned that I need to start spending time reading books, and I fell in love with reading history. And I've read well over 100 books since then through audio tapes, and it's been very enlightening to me. The situation that we're looking at today is very similar to some eras that have happened in the past. The last one that we encountered was in 1918 when we had the Spanish flu. This episode happened right at the tail end of World War I when all of our soldiers came back and then infected everyone here in the U.S. So that's probably the most significant time that we've encountered something similar. The world today is helpless, and we're all working together. There's almost no one left that remembers World War II and what it was like to begin that effort. But for those of us, the reality is, I feel like today that we've arrived at a point that feels like we're going into World War III, but we're fighting something invisible rather than each other, which is something that we can all work together on. And we have to realize that the world is sacrificing so much right now that we must respect those sacrifices and follow the rules to win this war. Everyone is sacrificing. Businesses are being lost. People are losing their jobs, things of that nature. So we have to keep that in mind with all of the efforts that we're putting into helping with this fight. Unfortunately, we do see a lot of people that are those that are not going all the way. Recently saw on the news that a student group in Kentucky had a COVID-19 party, just to, in spite of the whole thing, and one of them ended up contracting the disease. There's family disagreements on level of practice as we learn our way. It's a lot of trouble, a lifestyle I don't want to have to live, but we should strive to not be the problem or end up with a $100,000 hospital bill. So we need to try to keep ourselves well so that we're available to be able to help with this rebuild process. So I'm sorry, we have to cancel our vacations. This is reset time. We have to try to help to protect our elderly 60 plus to keep them harbored in safe places. In addition, they're the ones that are most likely that could end up in the hospitals. So we need to keep that number down so that it's available to take care of everyone that needs it. This is the third major global disaster the four of us APPA people here on the call have gone through. And basically the way we see it is it's a reset time. So we begin to, as everything begins to shut down, we work on the reset and then start the rebuild. One of the benefits of keeping yourself clean and healthy and taking all the precautions is my wife and I were taking a walk in our neighborhood and ran across an elderly woman that we were able to determine that she was lost and had Alzheimer's. I called 911 and described it to them, and they said, "Oh, great." And the first thing they asked is they say, "Is there any chance you've been in contact with someone with COVID or any risk of that happening?" I said, "No, actually, we've been very fortunate. We've been able to remain in our home for the last 14 days, so we're literally clean." And they said, "Great. Can you stay there and help with the situation?" So keep yourself available to be able to help with this and not be part of the problem. The world will be different forever. We're going to learn all sorts of new techniques that we've never thought of before. We're going to learn things that we've never thought of. We're going to further adapt to distant learning and the ways we meet and get together and become more efficient in a lot of ways that we're going to realize that we should have been doing this earlier. Those of us that survive will have an awesome opportunity to rebuild everything under the new way of thinking our world. One thing I predict to happen are for schools and colleges to learn and trust much more that they can educate with distance learning for a lot less money than the way we do business now, which is very costly, facility heavy. I've always been concerned with the level of facilities that we're building to get bigger and such elaborate facilities and just making the tuition more expensive. As a result, more students could be enrolled without adding more facilities, which will make tuition less expensive. And at this point, I think I will turn this over to Dave Irvin.
Well, good afternoon to everybody listening. I think if you listened last week, we talked about how things were changing literally by the hour. And here in Tennessee, that's definitely been the case. When we listened last week, we listened interestingly to our colleague at Iowa talk about a case on campus, but at that point, there were only a few cases in Tennessee. There were none in our part of the state. We knew it was coming, but we had no idea when. Since then, we now have over 1,000 cases in the state, a dozen deaths, and unfortunately, a number of people on campus who have contracted the virus, including one of our facility services workers. It's a gentleman who is in the hospital now, was on a respirator, thankfully is a little bit better today. And emphasizing what Dr. Huey said, this gentleman was not in those risk categories, under 50, good health, no pre-existing kinds of conditions that would say he was at high risk. So it emphasizes that this is a very serious disease, as we all knew. We've been talking here about this being a transformational crisis, kind of piggybacking on what Kevin said, and that it will require transformational thinking, not only how we get through this, but what we do afterwards. And we find that, at least on our campus, that facilities is a key to that. A lot of the changes or things that we have to do in the short term are more with our academic colleagues, our student life colleagues. They're not necessarily facilities related, other than cleaning and some of those kind of things. But because we're so good at emergencies, we sort of are often at the forefront. And because we touch everything, we have sort of that global perspective that many times other folks don't have. It means that we've got a unique role in this. And in terms of here at Tennessee, it means that we're thinking of those transformational things. Not only what do we do for this crisis, but as we hopefully transition out of this, what are the opportunities? For instance, here we have somewhere around 300 employees and 100 to 150 students who are going to be joining our facilities team in the next several weeks because there's no other jobs for them at the university. There are people like RAs and people that conduct orientation tours, serve food, etc. Obviously, we're going to make sure we keep them safe, that we do physical distancing, and will abide by the local constraints about essential business. but it gives us a transformational opportunity in this crisis to begin to think about how do we incorporate those folks? How can we make, our chancellor keeps talking about the wow factor, how can we make a transformational wow? And how do we do that, as Kevin said, knowing that the landscape is going to change dramatically as we emerge from this. The budgets are going to change. We're going to see huge slashes in budgets. Enrollment, which was already going to be challenged, is going to be challenged even more. So we've really been thinking sort of on a two-pronged thing. What's the transformation and the crisis that we need to deal with right now? And I know we're going to talk some more about that in this call, and I'm sure those are what most of the questions are, and which they should be. But I challenge all of you to be thinking about that transformational challenge and opportunity, not to get the cart before the horse, but to be thinking about what can we do when we emerge from this, because we're going to have less. So not how do we do more with less, but how do we do differently with less? And what does that look like? And how do we transform our institutions coming out of this very unfortunate crisis? With that, I'll turn it back to Lander, because I know we've got other things we want to cover yet this afternoon.
That's excellent. Dave, and Kevin, thank you. We're going to look at a few themed conversations from our panelists now. One about how you convince stakeholders your spaces are actually indeed safe for your stakeholders, your students, and the communications required. And then the next will be around the case and the need for rapid response when you have a coronavirus case. And then ultimately, what's the difference between essential versus critical staff and services that Dave Button's going to talk about? So let me go to Kevin Folsom now. Kevin?
Thank you, Lander. As facility managers, we begin to step back and look at the society around us. What are they doing, so that we can begin to find our place where we fit in and begin building our own institutions back, and as things are coming back. I look at society today the way it's being played out. All utility companies have to keep working, and we need to stay out of their way. Many colleges generate their own power and must keep it going. We have to provide them with a safe working environment by keeping all non-essential people away from them. Help them to feel safe that they're working and doing what they need to do to keep us all supported with utilities. Hospitals are the front line of the war. All the suppliers are working to get them stocked up with supplies, new meds needed, and so that they have everything they need. I recently saw a report where someone was donating 10 million masks to all the hospitals. And some of the numbers that I've seen is we only have 950,000 hospitals in the United States. So 10 million masks is roughly 10 masks per hospital. So we have large numbers, but we're still falling short from what we need to be putting out. And if you remember from history and things that you've seen in World War II, the entire country was coming together, and it was very unorthodox for women to work in the factories. We did everything different. We learned ways to be able to move ahead. I see in our neighborhoods people in their homes producing face masks and using AC filters and things like that, trying to create it to be able to mass produce all of these kinds of things. Grocery stores are open, but still going through the process of how to function in the new world. And while they are open to the public, they'll very quickly, they're going to have to produce standard procedures that all staff will need to follow, as well as patrons. Make very visible what they're doing. So as grocery stores begin to become stocked up, people are going to be selective where they can go and feel safe to be able to do that. Restaurants are being closed to indoor dining, but deliveries will ramp up. People are not going to buy food that cannot be washed like you get from the grocery store. If there is a lack of trust, the restaurant and delivery people are doing all the sanitary requirements. They will have to publish their protocols and prove they are doing it. Delivery people can work from car or home, but they must prove they follow protocols. People are going to have to be very outspoken about that and upfront. All the new sanitary supplies will probably go to these organizations first, is what I think might happen. our faculty, currently our faculty are working from home to provide online education. This is leading me to think how, as a facilities group, how can we support them at their homes? These are now our facilities to support. They're working out of their homes, and they need to be able to not be disrupted with facility-related issues. Considering things that we can do to help them. Maybe we need to offer those faculty with the sanitary supplies they need to make sure that we're keeping them well and have all the proper sanitation they need to remain well so they can continue teaching. Maybe they need some furnishings needs, utility internet reimbursements. Our facilities group can advise on home repairs if they have certain problems that are preventing them from teach. We don't want them to be disrupted by these home problems. We may be able to provide vetted contractors specializing in their needs. Maybe the schools need to consider home use reimbursement for the facility use of their space. And another thought is we could assign all of our fleet to one each of non-teaching staff to help with delivery of consolidated supplies from campus to the faculty that are working in their homes to try to keep them protected and productive. And with that, I'm going to turn it back over to Dave.
Thank you, Kevin. What I'd like to talk about a little bit this afternoon is what we faced here at Tennessee when we had the unfortunate incident of one of our employees who tested positive this weekend. And some of you undoubtedly have already faced that. I'd be interested to hear how you've dealt with it. It's a great example of what happens when an emergency plan meets the reality, because it's inevitably different. When that first happened, of course, our policy group was notified. Those of us heading facilities were notified. The policy group spent a day and a half trying to draft a statement about the individual. And of course, legal had to see it, HR had to see it. There was, 12 layers of people that had to see it and make sure that every V was in the right place. And when they finally issued it, it was a very generic document that really didn't tell you anything other than there had been an incident somewhere in Knoxville. In the meantime, social media almost instantly knew that this was happening. And while we didn't mention the individual's name in that press release because of HIPAA considerations, and that was appropriate, social media knew it almost immediately. And so the rumors were there 24 hours, 36 hours before there was even this generic statement. And so we in facilities had to figure out how do we deal with that, because of course the rumors were all over the place in terms of where this individual had been, who he had seen, that there were 47 other people who had been exposed and had the virus, and we were just not telling people because we didn't want folks to know. And so what it forced us to do was to, I wouldn't say go around the group, we would never do that. But we had to quickly augment what the policy group and the folks were saying. And again, I would not say that you would get crosswise with your leadership. We're always part of that leadership, but you need to anticipate that you're going to have to react much quicker, particularly if it's an individual in your area, than some of the other folks are going to be willing or able to react. So we've done a lot of things in terms of social media. We've done podcasts, we've done Zoom conferences. We already had a plan in place for how we would separate facilities workers. We put that in place quicker. We now have all of our folks working expanded shifts that are farther separated. We have people clocking in more different areas. We no longer use vans. All of our folks walk to the site, or only one person per vehicle. We've gone for those critical areas like utility services, central utility plant, to 2 isolated teams that don't interact physically, just electronically, so that if you have a key worker in a key area that is exposed to the virus, the whole team doesn't get it. And we put out information. We didn't put the person's name, but everybody knows who it is. We gave very specific information about exactly where that person was, exactly what that person's interaction was, exactly who they had come in contact with. The health department had already contacted the few people who were at risk. Luckily, it was an individual who was working our night shift in isolated areas. But that won't be the case probably for the next individual. So we've done a lot of things, and part of that is just dealing with the fear and the anxiety, because we have a whole subset of folks who are scared to come. They're devoted to this place, but because they weren't getting good information, they were convinced that we were putting them at risk. And so if you haven't thought through these things, you really need to do that, and you need to have a robust communication plan. I know that sounds kind of passe and sort of, well, duh, but it's even more important. And we also, in those areas, I'm glad to hear that we follow a protocol that Dr. Huey was suggesting. We waited 3 days. We did a full cleaning. In this case, we put people in full Tyvek suits, and we had volunteers that went into those areas. We accelerated the cleaning that we're doing in the places that our facilities team is all the time. We've done a lot of those kind of things, and we've been aggressive in getting that information out to our folks, in asking ideas from our folks. And then also for those folks who are working differently, working away from home, what are things we can do to make sure that their time is productive, that they're still part of our team, they're still helping our campus, and they're not just sitting at home worrying about what's going to happen. And all of that's very important. I'm sure you've all thought of that, but I guess what our experience has been is whatever you put together won't be enough. And you need to anticipate when this hits your campus, and more critically, when it hits your team, and it will. How are you going to respond to that in an instantaneous basis? Because whatever plans you have will be a good basis, but they won't be nearly enough for the kind of things you're going to have to respond to almost immediately. And with that, I'll turn it over to the other Dave, who's going to talk a little bit more about some of the things they're doing up in Canada.
Well, thank you very much, David and Kevin. And in fact, I'm going to build on exactly what you folks were talking about, in particular that aspect of fear. And I think one of the biggest challenges every university and facilities organization is thinking in that determination of who should come to work or not. And one of the biggest challenges is being handled and interpreted so differently in every jurisdiction and institution, even as we've seen between the three of us on this panel, anything from a great opportunity and a wow factor versus others who are basically almost frozen in place. The decision itself to come to work or not and to direct who is complicated, as it requires us to weigh the competing priorities between health and safety and reducing the number of vectors and flattening the curve through social distancing versus the other very simple economic situations and needs of both individuals and our businesses. And as I mentioned in the introduction about Canada, I think we might even be being hammered even harder and harder with the message to stay home, almost as though it's a duty and law, even though there's certain tasks like facilities that are deemed as essential and are indeed permitted by the legislators to carry on. This is confusing to our teammates at an individual level. And equally challenging at an individual level is the risk of not getting a salary, or at the institutional level of perhaps driving it to bankruptcy as it weighs heavily on personal finances as it hits all of us, and as people look into their pensions as it's taking a hit as well. So in the facilities business, it's even harder to take and resolve this dilemma, as there could never be a better opportunity for us to get work done than in this particular situation where the campus is empty and the workforce is available. All of our in-house team, our contractors, our consultants have never been more readily available because nobody is on vacation. They're all around here. So there was a great article published on this question in the Chronicle of Higher Education by Karen Fisher on Monday of this week. And it highlights that the university response to work during COVID-19 appears different for the different work groups on our campus. And that this is creating a significant feeling of divide amongst our teams. The challenge is that this is a fairly natural divide that has always existed, in some cases referred to between the academics and the rest of us, but it gets heightened when it feels like all of the, and I put this in quotes, the knowledge workers are safely working from home, and the, in quotes, the support workers are being put at risk by having to travel and work on site. And remember, even if we can take and make the site fully safe, which I think we can, there's still a perception that it is unsafe, and definitely the perception that things are being treated differently, or the two different work groups are being treated differently. So as we try and wrestle this reality, every campus and every jurisdiction has handled it differently. Therein lies another problem, as it's those differences between institutions that we then get played off one against the other, only making it more and more difficult to get consensus on our own campus. The various messages from politicians at all levels that have tried to guide us and generally say, stay home. This is what we need you to do. It does create a legitimate level of fear that David speaks to, and the facts that our institutions have come up to different conclusions, as we've seen in our own examples. And the individuals within our organizations pick and choose the example of the institution that is dealing with this in the way that best suits their individual arguments. So at our university, we struggle with this as well. As a further complication up here, we try to avoid the term essential in this disaster, as it was derived for a very specific circumstance that doesn't necessarily work in this unique situation. For us, essential positions is embedded in our collective agreements that we've got for every one of our unions. And so in this crisis, we've been using the term critical services to try and describe what needs to be done and how. And it's even that designation of critical services that seems to change almost every day as the legislative direction changes, the level of threat changes, and our workforce even changes. So I suspect we'll have lots of this discussion and questions in the Q&A period, but I'll just summarize by saying how we're dealing with it at our institution. So first, the two key questions. One, if you can work remotely, work remotely. And then the second, for all others, only do work that you can do safely. And for that, we've got 4 principles that help steer us in that regard. First, safety is paramount. We'll protect ourselves, our family, and our community. Second, we'll work together and hold each other accountable for managing our safety. Third, we'll watch out for each other as friends and colleagues. And this is getting to what Dr. Huey was talking about in terms of social solidarity. And then fourth, social distancing and safe practices will require how we change our thinking and our procedures. But we can do this safely. In fact, we do this safely all the time now. There's nobody like our facilities management people who know how to deal with hazardous situations. Our custodians are working with viruses all the time. Now it's just a different virus with a different skill set. So the good thing about these different principles for us is that it works for knowledge workers or support workers. And indeed, we know that many of our professors are coming onto campus to do their Zoom lectures because that's the best place for them to do it, because that's where their best equipment is. They might not have the same at home as resources. And we know our scientists are working around the clock in labs trying to come up with solutions and new vaccines. They need to work safely as well. And so those principles can apply to our trades folks, our custodians, our knowledge workers, etc. But it is definitely a difficult and evolving situation, and one that is emotionally charged. This is a time where it really takes leadership, and the solution is likely different on every campus, and it will change daily. With that, back to you, Lander.
Thank you so much, my two Daves and Kevin, for your comments, and also to Dr. Huey for his presentation to us. He answered so many of the questions across the board that we had last time and that were coming in this time. If we did not get to your question, we apologize, but we will be surfacing them and getting them back into our recently asked questions with responses. Excuse me, I have a tickle in my throat. So what I'm going to do is close us down for the day. And I want to make sure that you heed their warnings of turning this transformational challenge into an opportunity to do things differently. There was another Chronicle article. We'll get all these links, all these articles, every bit of it to you. But yesterday they said, communicate, collaborate, and pivot, meaning recognizing that the uncertainty of this global pandemic is a much more fluid situation with new facts and data, not every few days, but every few hours. We have to adapt and readapt our plans as the situation evolves. There is basically no playbook for what's happening right now. So I want to close with the following comment. Pay attention to your staff. Understand their needs beyond just the work effort that you need from them. That's the mental health side of this thing. Also, equally important, take care of yourself. Eat right, get some sleep, take a break. I know that's really hard, but there's such a thing as compassionate fatigue. You can't take care of others if you don't take care of yourself. Take time to clear your mind and re-energize so that you can do the work that we so desperately need you to do and that you have to do. We so appreciate you. We will be getting responses to all the questions back. There are resources on the pages that you see there for you to immediately access and more to follow. Let us know what it is you want to see from us. Next Friday's town hall is going to focus on planning, design, and construction because we really need to focus in on that education, and we have surveys coming out on those as well, and we'll be reviewing that. You need answers in that area as well. We're going to target and focus. Thank you, everyone, for your time and attention. We totally appreciate it.